Good afternoon, everyone. My name is Maria Echeverry, and I am a rising fourth-year medical student at Georgetown University School of Medicine. And today I have the privilege of presenting Assessing the Use of Laser in Treating Vulvar Lichen Sclerosis, a Narrative Review. Okay, sorry. Okay, thank you. So vulvar lichen sclerosis is a chronic inflammatory dermatosis that can lead to scarring and architectural changes of the female genitalia, impair sexual function, and can transform into squamous cell carcinoma. The standard of care for vulvar lichen sclerosis consists of ultra-potent topical corticosteroids such as clobetasol ointment. Decreased compliance or fear of adverse effects with chronic topical steroid use can lead to advancement of the disease, changes in vulvar architecture, and malignant transformation. Other than surgery, there are very few treatment options for the recalcitrant and more advanced stages of the disease that are unresponsive to topical steroids. Clinicians and researchers have sought to determine if lasers could be a viable therapeutic option for lichen sclerosis, specifically for the scarring and more progressive treatment-resistant forms. To conduct this narrative review, the PubMed database was utilized using the advanced search terms laser treatment and vulvar lichen sclerosis. This resulted in 58 unique articles which were examined for relevance to the research question and if they met inclusion criteria. A total of 36 articles were reviewed. And for the fractionated CO2 laser, we found that 2 randomized control trials comparing fractionated CO2 laser and clobetasol found greater improvement in several symptoms and physical exam findings in vulvar lichen sclerosis in the laser group, although no major anatomical or morphological changes of the vulva. Another study saw improvement in maintenance in all clinical signs and architectural changes when laser was used as an adjunct to clobetasol. A report of a series of patients with recalcitrant hyperkeratotic vulvar lichen sclerosis achieved remission following fractionated CO2 laser and were able to maintain with topical steroids thereafter. Interestingly, one prospective study evaluated the histopathologic changes before and after fractionated CO2 laser and found significant improvement in sclerosis and epidermal atrophy, which correlated with symptomatic improvement, while a randomized control trial found no significant difference in histopathology or the clinical scoring system between fractionated laser and sham laser groups. CO2 laser has successfully treated vulvar lichen sclerosis with maintained resolution of symptoms and release of labial adhesions in patients with recalcitrant disease. CO2 laser has also been used to successfully treat clitoral phimosis and provided patient relief when used for vulvar skinning resection, although recurrence was common. Holmium YAG laser plus ALA PDT were found to thin hyperkeratotic regions, reduce vulvar lichen sclerosis lesions, and decrease symptoms. Interestingly, sexual function disorders were stable after treatment except lubrication disorders. However, depression, as represented by the Beck Depression Inventory scores, was decreased. Erbium YAG laser has been shown to improve several symptoms and the impact of vulvar lichen sclerosis on patient lives, including in those that were unresponsive to clobetasol. Another group successfully used YAG laser for recalcitrant hyperkeratotic vulvar lichen sclerosis with phimosis and scarring over the clitoris using topical steroids for stabilization thereafter. However, one reviewer found that half of the RCTs evaluating CO2 or YAG laser did not find a significant difference in improvement, while most non-comparative studies reported significant improvement after laser. The ND YAG laser was found to be superior over topical steroids in patient symptoms, sexual satisfaction, reduction of sclerosis, and clinical improvement. Despite the changes in sclerosis, one study found no differences in the change of epidermal thickness or degree of inflammation with the use of laser. So in conclusion, the use of laser therapy for treatment of vulvar lichen sclerosis is a rapidly growing area of research with significant new findings over the last several years. Several studies noted the ability of laser therapy to treat hyperkeratotic or recalcitrant cases of vulvar lichen sclerosis. These findings may be due to the laser's ability to remove hyperkeratotic regions and allow both laser and topical steroids to better penetrate the area and provide a therapeutic effect. Studies have shown histological improvement in the degree of sclerosis following fractionated CO2 laser, suggesting an effect on the scarring component of vulvar lichen sclerosis, which currently has very few treatment options. As clobetasol is known to treat the inflammatory component of vulvar lichen sclerosis, laser may become a useful adjunct therapy for the sclerosis and architectural changes in a progressive disease. Although many of the studies evaluated have demonstrated the efficacy of laser for treatment of lichen sclerosis, others have noted that evidence becomes less supportive in studies of higher quality. For these reasons, the ISSVD has yet to recommend lichen sclerosis as an indication for laser therapy. There has been a large increase in the number of studies and data investigating the effects of lasers for VLS since these recommendations were made, and updated guidelines are needed. More robust, high-quality studies are recommended to provide more clarity on the use of lasers in lichen sclerosis, and several clinical trials are underway. Additionally, clear reporting of settings and methodology is needed. Thank you for listening to my talk, and special thank you to Dr. Arisa Aliyah, one of my resident mentors, and Dr. Allison Larson, one of my attending mentors, for helping me with this project.